But it's 4 o'clock on the dot, so let's get going. Welcome everyone to another edition of Tumor Talk. This is the collaborative effort between the Journal of Neuro-Oncology and Lennox Hill Neurosurgery, where we bring in authors of recent publications in the journal, and we discuss the reasoning for their study, the rationale, the results, and probably most importantly, the relevance. And so today, we're pleased to have Tareq Juratli, who recently edited a special issue of the journal on low-grade gliomas. And it's a great issue. It really runs the gamut in terms of how you think about this disease. And we're delighted to have some contributors as well. So Tareq, please take it away. Tell us about the issue. Tell us about the kind of key findings and or key studies that you think are important.
Yeah, sure. Thank you very much, Randy, for having me today on Tumor Talk to share and promote our special issue. I'm gonna share my screen. I guess you can see my screen now, right?
Yeah, it looks perfect.
Yeah, perfect. So this special issue is on diagnostic and therapeutic implications of IDH mutations in gliomas following the 2021 WHO classification of CNS tumors. And it has been a great honor and pleasure to publish in Journal of Neuro-Oncology. And I'm going to introduce myself a little bit. So my name is Tareq Juratli. I'm Associate Professor for Neurosurgery and the Director of the Neuro-Oncology Center at the National Center for Tumor Diseases in Dresden. Together with my colleagues, Christine Jung, who is the Vice Chair of the Department of Neurosurgery at the University Hospital in Heidelberg, and with Julie Miller, who's Associate Professor for Neuro-Oncology at Mass General Hospital, whom I'd like to thank both for their exceptional collaboration and support. Together, we co-edited this special issue, and where we focused basically on IDH mutant gliomas, looking for cutting edge research and to have nice papers and manuscripts and genomic discoveries, recent diagnostic techniques, and therapeutic advancement and neuropsychological aspects in IDH mutant gliomas. So this is a very unique group of patients with these tumors. And as the last WHO classification has shown, these tumors should be treated differently than other tumors. So, and this is exactly the focus of our paper. And I'm gonna start to walk you through a couple of these interesting articles in this special issue, beginning with this very nice review from Sam McBriar from the University of Texas Southwestern Medical Center, who discuss in his group, describes the current understanding of how IDH mutations impact DNA damage in gliomas. So they describe how DNA damage can be categorized based on gene expression, sensitivity to alkylating agents, the disruption of homologous repair, and response to oxidative stress. So for people who are really interested in understanding how that works with PARP inhibitors and so on, this would be a very nice review to read in this special issue. Next, David Royce from the University of Heidelberg describes and provides a summary of the changes related to IDH mutant gliomas according to the updated WHO classification. He highlights the clinical relevance of molecular features that are now used for both classification and grading. So if you wonder how should I consider grading IDH mutant gliomas, this would be a very nice review how to do it and how to use methylation profiling as well in your diagnosis. So David Royce works in the University of Heidelberg with Professor von Deimling. So this would be a very valuable review for people who want to understand how that works. Next, like our co-editor, Christine Jung, and her group published a very nice paper, How to Treat Elderly Patients with IDH mutant low-grade gliomas, where they showed that patients who are elder or older than 60-year-old, that those patients would have comparable surgical outcomes and progression-free survival if treated like young patients. And they highlighted and concluded that those patients who are older than 60 with an IDH mutant mutation in their glioma, they should receive the same treatment as young patients. So again, this shows how important this classification of IDH mutation is, especially or in particular also in elderly patients. Anti-Vic from University of Heidelberg with Tobias Kessler, they discuss treatment approaches for oligodendrogliomas and astrocytomas, including maximal safe resection, radiochemotherapy, and diagnosis and surgery alone based on histopathological diagnosis and prognostic factors. So this review will walk you through how, or like shows you an algorithm how you should deal with your IDH mutant patients if they have an IDH mutant astrocytoma, or if they have an oligodendroglioma based on grade and so on, how they should be treated. So this is a timely review how to treat your patients based on their molecular and histological diagnosis. Norbert Galdix from University of Cologne and his colleagues, they wrote a very nice review about the value of PET studies in glioma patients with an IDH mutation. They focus in their review on the potential use of PET probes targeting the IDH mutation for response assessment in clinical trials using IDH inhibitors for treating IDH mutant gliomas. And if you think about the upcoming trials on target treatment with IDH mutations, so the PET diagnostic is gonna be the future, how to assess your patients on how they react to that, or how do they go with the treatment with a target inhibitor. Notably, we have two very interesting articles and studies on the efficacy and safety of proton radiotherapy in IDH mutant gliomas, and Laila is gonna go through her paper, very interesting paper, to show how great that works in IDH mutant patients. I'm not gonna talk about that, but we had like two studies showing similar results on how good radiotherapy is, proton radiotherapy is for IDH mutant patients, and about safety and efficacy of this treatment. Lastly, Mike Parsons has written a very nice review with his colleague about the cognitive issues in IDH mutant gliomas. So patients with an IDH mutation would have different cognitive issues than patients with IDH wild-type glioblastomas, and Mike is going to talk about that also shortly during today's talk. So in summary, this special issue is timely and provides a comprehensive overview of about the last research in this field. And if you think about targeted inhibitors and how that important is for IDH mutant tumors, just think about the ASCO news that we just heard yesterday and this New England Journal paper from Ingo Mellinghoff and the Indigo trial studies results about vorasidenib in IDH wild and IDH mutant glioma, showing very significant difference in terms of progression-free survival of patients who got that target treatment. So again, this is a very timely issue and very timely topic, and I'm glad that we had the opportunity to highlight this in today's Tumor talk. Thank you, Randy.
Thank you. Yeah, I agree. I think, the timing of the issue couldn't be better with this recent publication. And I think as with everything, there's more questions than answers, even with big studies like this coming out. Who else? You said someone else was going to present a little bit here?
So Laila and Mike, both of them are going to show their articles and describe their findings.
Yeah, let's dive right in. We like to keep things under a half hour if possible.
Yeah, perfect. So Laila?
Yes, thank you. Just a second, I'm sharing my screen. Okay, I hope you can see everything.
Yes.
Okay, thanks. Thank you for the introduction, Dr. Juratli. I'm going to give a short overview about our publication. about analysis and safety and the analysis of safety and efficacy of proton radiotherapy in IDH-mutated gliomas. My name is Laila König. I'm a senior consultant at the Department of Radiation Oncology at the University Hospital in Heidelberg. And we have the opportunity to treat patients with photons, but also with protons, since we have the Heidelberg Ion Beam Therapy Center. And that's what we are investigating in our research group. So I think the background is clear that IDH mutation significantly influences prognosis in glioma patients, and radiotherapy is one of the main and central pillars of the treatment, as it was shown in several trials. Most trials, nevertheless, use photon radiotherapy techniques like 3D conformal radiotherapy or intensity modulated radiotherapy. Nevertheless, a newer modality, which is proton radiotherapy, has superior physical advantages compared to photon radiotherapy, and is over the last years gained more importance in several entities, also in glioma patients. And it is discussed highly since there is a probability of a higher risk of radiation necrosis. This is why our research group is interested in the understanding of those contrast enhancements. We call them RISE, I will talk about that as well, after proton radiotherapy. And we are also investigating if this physical advantage translates into a clinical outcome advantage in those patients. Here you can see a photon and a proton plan in the same patient, and you can see quite easily that the tissue sparing of the surrounding healthy brain is much better with proton radiotherapy. So what did we do in our analysis? We investigated patients that had been treated with radiotherapy from 2010 to 20 at the Heidelberg Ion Beam Therapy Center, which you can see here on the right side. All patients with IDH-mutated glioma. We used our internal HERO database, but also the National Tumor Register. And in total, we reviewed more than 2,400 MRI scans. We correlated those scans with our radiotherapy plans in our planning software, which is called RayStation. The endpoints were effectiveness measured with the PFS and the overall survival, but also toxicity according to the CTCAE criteria. We use the term radiation-induced contrast enhancement, abbreviation RISE, in our research group, and we defined it as new post-contrast enhancement, post-treatment contrast enhancement in the surrounding brain tissue within the 80% isodose. And in our patients, we confirmed them longitudinally with all additional follow-up MRIs we had and all the other available information. That means MRIs, RT plans, medical records, tumor board, etc. The aim is hereby to minimize the misinterpretation of RISE as tumor progression, as we already showed in another publication in 2022, where we had a misinterpretation rate of 39% in those patients. And we also adapted the German Society of Radiation Oncology practical guideline regarding radiation necrosis classification and diagnosis in our publication. So I'll dive into the results. If we look at the patient characteristics, it's the classical glioma patients, so we have approximately 60 to 40% male-female ratio. The patients were in quite good performance status, and we had around 60 to 40% astrocytoma to oligodendroglioma ratio. Regarding the treatment characteristics, you can see that 33% of the patients had biopsy only, but the other approximately 68% had a subtotal or total resection. Treatment with radiotherapy was according to the guidelines. That means for grade 2 tumors, we used a median dose of 54 gray, and for the higher grade 3 tumors, we had a median dose of 60 gray, RBE. RISE occurred in quite a large amount of all patients. In 25% of all patients, we saw RISE occurrence, and it occurred after a median of 16 months with a range from 2 to 41 months. As you can see here in the RISE-free survival Kaplan-Meier curve, we had much higher rate in WH grade 2 tumors, so 29 to 70% in grade 3. This difference was not statistically significant. but we saw a statistically significant increasing risk with higher age in those patients. Regarding the toxicity grading, we had the large amount where patients, 69%, without any symptoms at all with their RISE, and we had only 4% higher grade 3 and no more than grade 3 toxicity. RISE-directed therapy, that means dexamethasone or bevacizumab, was also applied in a smaller amount of patients, in 35% of the patients, and 53% of the patients had a radiological response, and 29% had a symptom response with a relief of their neurological symptoms after RISE-directed therapy. 65%, so the large amount, didn't need any therapy at all, so they were mostly radiological changes without any symptoms, and in most of the cases, in 2/3 of those cases, we saw a regression by its own after 7 months. We also investigated if there's an influence on overall survival of RISE, and interestingly, we did not see any negative influence on overall survival in our cohort, as you can see here on the right-hand side. And this is quite an interesting point, which is discussed openly in the community, that this might be a problem in patients treated with proton radiotherapy. Regarding the effectiveness, we had a median follow-up of 5.1 years, and the 5-year overall survival was 85% in grade 2 and 67% in grade 3 tumors, and this difference was significant. And the PFS rate was 60 to 30%, also with a statistically significant difference in those patients. So finally, I would give a short summary and conclusion about our manuscript. So this is the far largest cohort with long-term clinical but also radiological follow-up and outcomes in IDH-mutated glioma after proton radiotherapy. We can say that proton radiotherapy is an effective treatment, since we show overall survival rates after 5 years of 85 and 67% in our cohort. And with these rates, it is comparable to the classical photon trials of EORTC, RTRG, and also the Cadnon trial, with probably one of the best molecularly analyzed cohorts. The overall survival is also similar to a smaller prospective proton trial from MGH with 20 patients. They had almost the same 5-year overall survival. And nevertheless, we don't have any direct comparison so far between photon and proton radiotherapy. There are prospective trials ongoing, and the results are awaited eagerly. We have to say that RISE occurred frequently, so 25% is a number you have to explain to the patients, but we can say that it did not influence the overall survival negatively. We found risk factors, or we found a higher occurrence in older patients and in grade 2 tumors, and most of the patients didn't have any symptoms, but we have to say that there is a high risk of misinterpretation as progression, and maybe progression-free survival is also probably too low in some of the historical trials, therefore. What is very important to say to the patient before we start with the treatment, I think, is that even if they have RISE and they might suffer from symptoms of it, they have a good response if you treat them correctly with a RISE-directed therapy like dexamethasone or bevacizumab. Yes, I'm at the end, and thank you very much for your attention.
Thank you, Laila. That was great. Michael, do you want to queue up real quick? Sure. We'll save questions for the end. And while you pull up your talk, I just want to remind people this is interactive, so people viewing can feel free to write in the Q&A and chat with us as well.
Okay, are you seeing my slide there?
Yes, we do.
Okay, great. So I think to follow Dr. König's talk is a perfect transition here to talking about cognitive outcomes in patients with IDH mutant gliomas, because I think, as we all know, one of the biggest concerns our patients have is about the potential cognitive consequences of treatments such as radiotherapy, and ideally having advanced treatments like protons to reduce that risk is critical. But my review in this issue, which I was so honored to be invited to participate in, was really about how to conceptualize cognitive issues in patients with IDH mutant tumors and the ways in which that might differ from other gliomas, and how to integrate clinical neuropsychology and cognitive outcomes into both clinical care and research for these patients on a routine basis. You know, I think many of us know that there is a lower rate of cognitive impairment with IDH mutant versus IDH wild type tumors, which was originally demonstrated by the MD Anderson group in 2016. And as the understanding of the way in which IDH mutant tumors influence the brain has increased, mostly through research using connectomic methods such as MEG on the left here or resting state fMRI on the right, what we found is that the IDH mutant tumors are less disruptive to widespread neural networks throughout the brain than IDH wild type tumors, probably because of their reduced growth rate and tumor momentum, but perhaps also relating to the ways in which gliomas integrate with neural networks. As we all know, the integration of neurons into gliomas and gliomas into neural networks at a cellular level has recently been revealed and started this whole new field known as cancer neuroscience. Almost all of that research has come from glioblastoma work, and very little is known at this time about the ways in which glioma cells interact when they are IDH mutant tumors with existing neural networks. But I think we can assume that the infiltration or ways in which the glioma drives neural reorganization differs between the wild type tumors and mutant tumors. This image here is from Sean Hervey-Jumper's recent Nature paper, in which he very elegantly demonstrated that glioma growth not only drives neural reorganization, but integrates in a functional way with neural networks. In terms of taking this information and applying it to care of patients, our article reviews the role that neuropsychology and intraoperative mapping can play in making optimal neurosurgical resections. In other words, balancing the oncologic outcome with the functional outcome. David Sapsovitz, my co-author, has developed an application to really advance the practice of intraoperative mapping, known as his application is known as NeuroMapper, and I have it demonstrated here on the left in use with a patient being shown a stimulus and allowing integrated interaction with the neuropsychologist and the electrical stimulation, all in a very nice package that will facilitate research into intraoperative mapping techniques. And David leads a monthly discussion of neuropsychological surgical mapping at this link on the right. If anybody is interested, it is a true interactive session where cases are reviewed and discussed on a monthly basis. Ultimately, we propose a model for integrating neuropsychological care into the treatment of patients with IDH mutant tumors in a way that is both feasible and relatively integrated with patient outcomes, including integrating neuropsychological assessments at the preoperative time point. That includes baseline testing for the intraoperative mapping procedures when relevant, and a short-term follow-up to allow for measurement of outcome after surgery and assist with rehabilitative planning when necessary. That is typically followed by a comprehensive, more in-depth follow-up for cognitive outcomes a few months after, usually after an initial phase of treatment, such as proton radiation, as Dr. König mentioned, and then long-term monitoring and follow-up over the lifespan for patients living with IDH mutant gliomas and the after effects of their treatment. The article, I included a case of a patient who I've seen recently. The images here are from a 21-year-old right-handed young lady with a large IDH mutant tumor involving the insula and inferior frontal lobe, anterior temporal lobe on the left, who was identified because of seizures. She was seen for a pre-op neuropsychological battery and showed very mild language-related deficits at the pre-op time point. She underwent intraoperative mapping and resection, was found to have some areas to the anterior margins of the tumor that induced speech arrest. So based on preoperative discussions with the patient, the family, integration of the fMRI mapping, the decision was made to achieve a subtotal, near total resection, leaving part of the tumor intact that may, as it grows, facilitate reorganization. Nonetheless, in the immediate postoperative period, she had a marked decline in naming and word retrieval, as well as some milder declines in her working memory for verbal information and her rate of reading. She then underwent initial treatment with radiation therapy and concomitant chemotherapy. This proved to be a grade 3 IDH mutant astrocytoma. And at the postoperative time or at post-treatment time point had a significant recovery of her basic language functions, but had persistent verbal working memory and reading rate problems. We worked with her in the neuropsychological feedback to design some accommodations. She returned to college and has just completed the first semester of her senior year successfully with those accommodations. So this is a case that illustrates the importance of integrating cognitive assessment and guidance of those rehabilitative efforts throughout the course of illness for a patient with IDH mutant glioma. Was highly integrated and effective for the patient and family. I'll pause there. I know there may be questions or discussion about all these pieces.
Yeah, no, I mean, first and foremost, thank you all for participating today, and thank you all for putting together a really fantastic issue for the journal. Tareq for editing it, obviously. I speak on behalf of Jason. I know just being appreciative of the hard work and great work that people are putting into the journal. And then, being available to come here and chat with us about it. It's often insightful to get the author or the creator of the study's insight into why they did the study, right? Sometimes the language in the article doesn't, fully convey everything that the person behind it was thinking or the relevance of it. So we have one question from the group here that are listening. Someone asked, what are the types of tests that were done in the pre-op baseline assessment?
Sure. There's usually a brief battery of neuropsychological tests that we would do at the preoperative time point. There's a few core tests that we routinely do with almost everyone that include things like memory, verbal fluency, processing speed, basic language skills like confrontation naming. And then, of course, the battery is adapted to meet the potentially relevant cognitive issues of the patient based on tumor location, the patient's level of functioning, and other factors like that. We also include, when we're doing intraoperative mapping, all of the procedures that would be part of the operating room cognitive assessment. So in this case, that included things like routine rapid naming tasks, auditory naming tasks in her case, and a few verbal working memory tasks that were integrated in the intraoperative mapping procedure, so that we know prior to going into the operating room which symptoms might be representative of tumor-related disruption of functioning, and don't make any mistakes about whether those performance difficulties in the operating room reflect stimulation versus already present deficits.
Thank you so much. Laila, I have a question for you. You guys have the luxury of having a proton center nearby. I actually have that benefit. There's one close by. It's not affiliated with my hospital, but it's nearby enough. And Michael, I think there's one close to you guys as well. And so my question is, Laila, are you doing this for every low-grade glioma now? How do you choose who gets proton, who gets photon?
Yeah, that's a good question. It's not really easy to answer this question because I think that's dependent from a lot of parameters. So first of all is the health insurance. It's also a topic in Germany, and we have a different health insurance system than you guys in the US, and so we have contracts with certain health insurers, and if we have this contract going, we are allowed to treat those patients with proton therapy because we made this contract years ago to show efficacy, safety of proton therapy in those patients. So probably these contracts are going to be on a broader basis now after this kind of publications. And so that's one of those things. So some patients that have a certain insurance won't be able to get it either, or they pay for it on a private basis. But those are in Germany, not that many patients like in the US, for example. That's the first thing. And the second thing is that we try to offer it to patients that have a large tumor, younger patients, for example, the patients Dr. Parsons just showed with this temporal localization, those patients where we think that they might benefit from protons, especially due to the better sparing of the ejectant organs at risks. Maybe organs at risk like hippocampus, but also optical system, brainstem,
Yeah, makes a ton of sense, especially for those larger lesions, like you're saying.
Go
ahead, Michael.
That you referenced, Laila, Dr. Xi's prospective studies that she's been running since 2006, looking at proton outcomes, and she has integrated neuropsychological assessment longitudinally in those patients in many studies, and we're now collecting, our current sample is aiming at a recruitment of 100 patients where we collect neuropsychological outcome data in addition to the others on an annual basis every other year after 3 years out from treatment. But as part of that, we're looking at sort of trying to advance the outcome metrics above and beyond survival to look at the relationship between individual risk factors such as age, tumor characteristics like size and location, and risks for not only survival, but things like cognitive outcome down the road. Obviously, the randomized study you referred to will be a great advance in the field in terms of truly understanding the potential benefits of protons over photons in this population.
Yeah, Michael, you stole my thought. I was going to go that way and say, with the hippocampal sparing. You know, actually, we're curious about NeuroMapper. We just hired someone who has a good experience with it. Right now, I use a standard neuropsychological evaluation, but we're looking now heavily into connectomics as well. And so we need a standardized, system, basically to be able to evaluate these patients, fairly rapidly without a 4-hour battery pre and post-op. So I've heard good things.
Yeah, I think, what NeuroMapper offers is a high degree of reliability and a much greater degree of sensitivity because it's integrated with the stimulation equipment so that you can quantitatively measure things like delayed response time after stimulation, which is much more sensitive than just saying they got it wrong or they couldn't speak or something like that you'd otherwise do. So being able to quantify the degree to which a stimulation location delayed the onset of a response is going to really enhance your sensitivity to things, like the image I showed from Sean Hervey-Jumper, where we know that tumor-infiltrated cortex is playing a role and a different role in the way it's responding to cognitive activity. So what David's built, I think, gives us a framework. It's being utilized in many centers. I know already big centers like MD Anderson are integrating it in their intraoperative mapping as well. So I really advise David's webinars, the third Thursday of every month, are they're a masterclass in functional neuroanatomy and the integration of intraoperative mapping with neuropsychology and neurosurgery. So
I'll get the link up here. It sounds super interesting. I'm going to throw one more question out there. It's almost 32 minutes. I'm a little bit over, but with the recent study that just came out in the New England Journal, I'm sure everyone's still digesting kind of what that study was and what it means. Are we looking at low-grade gliomas? Are we going to see another revision of how we classify these things in a few years? Should we be looking at grade 3s, the same way? It seems that, once a tumor starts enhancing, it's kind of escaped the IDH, the relationship or the need for an IDH mutation, and it becomes more malignant. Are we thinking that down the road that, grade 3s obviously are high-grade gliomas, but maybe they're really further removed from our grade 2s than we ever, previously thought? What are you guys' thoughts on that?
I think that's exactly the problem. So how to distinguish between grade 2 and grade 3? Even if you ask any pathologist, could you tell if it's a grade 2 or grade 3? It's not always easy. I think like the most important step right now is to know how to differentiate between grades 2 and grade 3 once they are IDH mutant. And I think like this feature of contrast enhancement is not really a feature that we can rely on, because you would have 30% of grade 3s that don't really enhance. So this is nothing we can really use in daily routine, I guess. Sometimes we do, but it's not really reliable. I think we need better criteria, and I think we're on the way because like the Indigo trial is very interesting, of course, but those are patients with low grades and so on. We would have different patients, and the question is, how do we measure the success of our treatment? So is it like with PET, or is it with a different diagnostic? So we have a lot of tools and advancements that we have to understand in the future. And I think the PET diagnostic is interesting once we have an IDH specific tracer. So once you have it for IDH mutant tumors, then you are on the right way. But again, it's not that easy because you have different variants of IDH mutations and so on. So it's a really complicated topic, I guess.
It is, without a doubt, but it's exciting. And
It's
so
exciting.
I'm looking forward to more work from all of you guys on everything. Thank you guys so much for being a part of this. I can't express my thanks enough. It's been a great time. And, you know, this will get uploaded so you can share with all your friends and everything. We had a great turnout today. I thank everyone for tuning in, and we'll see you next time.
Thank you very much.
Bye.
Thank you.
Take care.
Have a good one. Thanks. Bye-bye.